Good evening, everybody, and thank you for joining us for TMA's statewide teleconference on COVID-19 pandemic. Tonight, you'll hear from some of our state's leading authorities that will help you coordinate state level and community communications specific to the expected surge in testing and the treating of positive cases. Many of the questions that you may have tonight may already be answered in resources provided by the CDC and by the Tennessee Department of Health. And you can find those links to those agencies and more insight at TMA's website, tnmed.org/COVID, or at the Memphis Medical Society's website, mdmemphis.org. There you'll find a number of frequently asked questions from physicians previously submitted. With that, our presenters this evening will be Dr. Manoj Jain, an infectious disease physician currently consulting with the city of Memphis on all COVID-19 matters, and Dr. Michelle Fiscus, the medical director, Vaccine and Preventable Diseases and Immunization Program with the Tennessee Department of Health. We're going to ask Dr. Fiscus to start us off this evening. And I want to remind everyone that there'll be a Q&A portion at the end of the presentations. With that, Dr. Fiscus, will you start us off?
Thank you. It's great to be with you. I appreciate the opportunity, and I'm going to share my screen with y'all so you can see a few slides. Can you see that okay? Make sure I'm sharing with you.
Okay.
There we go.
There we go. There we go. All right. So I am the medical director of the state's Vaccine Preventable Diseases and Immunization Program here at Tennessee Department of Health, a pediatrician by training and a member of TMA. And I just wanted to spend a few minutes giving you a little bit of an overview of what's going on from a national and state level with COVID-19. We actually stood up our incident command structure here at Department of Health 85 days ago in the middle of January, when we first learned of what is now the pandemic. And it has been 35 days since the first case in Tennessee. We have a clinician call line that's here at Tennessee Department of Health that is staffed from 8 in the morning to 8 in the evening, 7 days a week. That number is 615-741-7247. And clinicians can call that line during those hours to request testing through the state public health lab, which typically has a 24 to 48 hour turnaround time. If you have someone who's in a high risk category or an uninsured patient who might need COVID testing, we would be happy to assist you with that. There are several information lines set up for the public across the state. You can see several of those here on the screen, and there are others in addition to these. The two that are run by the state are on the left side of the screen. One is actually manned over at Tennessee Poison Control Center, and the other one is manned at TMA. And in both those situations, we have folks that can answer questions from the public, along with several lines across the state with different Department of Health regions that can answer questions from your patients or other members of the public. So right now in the U.S., Tennessee ranks as one of the states with some of the higher case counts compared to other states in our region. There are certainly states that have more cases than Tennessee. Those are primarily on the coasts, and then down in Florida and in Texas. And then the epi curve for the United States is down at the bottom. You know, a lot of folks have talked about flattening of the curve. It's probably a little premature to talk about that at this point because testing has lagged and kind of ebbed and flowed through this so far. And so the number of cases that we have is directly related to the amount of testing that we're able to do. So as we see more testing across the state, we'll identify more cases, and this epi curve will look a little bit different over time. We at the Department of Health post updates to the state numbers every day at 2 o'clock, 7 days a week on our website. You can find that at tn.gov/health and click on the yellow banner at the top of the page, and that will take you to this site that you see on the screen that posts all the numbers each day. Today we announced 4,634 cases in the state with 94 deaths, and you can see on the screen our epi curve as of today for the state. Again, you need to look at the red trend line more so than the blue bars that show daily numbers of cases, because there are days when we have 5,000 test results come in, and there are days when we have several hundred test results come in, and all of that affects how many cases we're able to identify and report to you. We have that information broken down within the 13 regions across the state. The Mid-Cumberland region has a little over 1,200 cases. Those are the counties surrounding Davidson County. Davidson County itself has about 1,000, and then the Memphis-Shelby area also has about 1,000 cases. And then on the right, you'll see a pie chart with the proportion of deaths. As you would expect, we have the largest number of deaths in the most elderly of our patients, with 32% of them in the 81 years plus age range. Overall, there are about 82% of the deaths in the state are in the 61-year plus population. The state of our beds and ventilators is something that comes up a lot. So right now, as of today, we have 35% of floor beds available. This is reported to us from the hospitals across the state. About 33% of the ICU beds are available. About 50% of the airborne infection isolation rooms are available, and about 74% of the ventilators. And these numbers had actually been fairly stable since the first of the month. We've been hanging out right around 32 to 35% of the beds across the state that have been available. Those alternate ventilator numbers include things like anesthesia ventilators that aren't typically used long-term in intensive care units to assist patients. And then there are some alternative ventilators like pediatric ventilators that can be reconfigured to be able to handle adult patients. We do influenza-like surveillance across the state. We have volunteer practices that obtain swabs for us throughout the year on any patient who has fever and cough. That counts as an influenza-like illness. And so you can see both the Tennessee numbers in red and the U.S. trend in the dotted line to show that you can see the peak of the influenza season, which was in December, and then we had a little bit of a second peak in early January and February, but now we have this sustained elevation in what usually is coming down at this time of year, and that's because we're picking up these COVID cases through our ILI surveillance. So down below, I've superimposed the flu activity. These are actual flu positive tests in this lower graphic, and that's imposed on the same timeline. So you can see that while the number of influenza positive testing that the CDC has seen nationally has come down as expected through the season, the national numbers continue to remain elevated for ILI, which is an indication that we're picking up these COVID cases through this surveillance. Just for more information about that Sentinel provider network, this is something that's critical to our ability to both track influenza-like illness throughout the year, but also to be able to identify novel viruses that may cause pandemics like this. We are always in need of practices that are willing to do surveillance testing for us and submit swabs to the state. If you're someone who might be interested in helping us with that work, you can email Cassandra.Jones forms at tn.gov, and we would be happy to enroll you in that program. Also on the Tennessee.gov site, if you go to tn.gov and then click on the red banner at the top, that takes you to the governor's page, and there you'll see a tag for remote assessment sites. If you click on that, you'll see all of the remote testing and assessment sites that have been stood up across the state, and you can click on those by county and find places where you can send patients to be assessed and potentially tested for COVID-19. The public health sites will be open tomorrow, which is Good Friday, and also over the weekends, over at least the next few weeks. There are numbers on that website where you can call specific locations to find out what their operating hours are. There are a couple of resources out there right now for providers who maybe aren't accustomed to working in the ICUs, just in case we should end up needing to recruit non-critical care providers to do critical care work. People like pediatricians who might be recruited to work in an ICU that has been stood up in a pediatric hospital. One is the Popcorn Network, which is the Pediatric Overflow Planning Contingency Response Network. They have some self-assessment tools and videos there that can help guide you to become a little more prepared and refamiliarized with working in an ICU. And then there's this COVID-19 Resource and Response Center that also has some online videos that might help you prepare in the case that you would be deployed to an adult facility or an ICU where perhaps you're not accustomed to working. And then I'll also remind you about the Medical Reserve Corps. You can go to that same tn.gov/health page, click on the yellow bar, and that will take you to a place where you can sign up to volunteer in the Medical Reserve Corps. Whether you're a clinician or not, there's an opportunity to sign up there and potentially help us with surge capacity if we were to need that. And again, for up-to-date information, tn.gov/health is where you'll get our 2 p.m. posts of all of the Tennessee updates, and then cdc.gov/coronavirus has constantly changing information on all things having to do with coronavirus, lots of places for guidance. In addition, on Fridays, every day at noon, here at Department of Health, I host a webinar that gives Tennessee updates. That's at noon, and those are also archived at the tn.gov/health website. So with that, I will send things back over to Dr. Jain, and I appreciate the opportunity to speak with you this evening.
Great.
Got to unshare my screen.
Well, welcome everyone, and thank you for taking time. And I will share my screen as well. It is quite busy screen here, but I think we can. My name is Dr. Manoj Jain. I'm an infectious disease doctor in Memphis, Tennessee. I also teach at Rollins School of Public Health and also write for the Washington Post and the Tennessean, as well as the Commercial Appeal. Well, about a decade ago, I remember distinctly being in an infection control meeting, and one of the folks asked me, it was during the avian flu, and things were not bad very much, but things were still somewhat concerning, and someone asked, Dr. Jain, what keeps you up at night? And I was pretty clear in my answer. And I said, if we had a virus which had a higher mortality rate than the flu, and if we had a virus that was more infectious than the flu, that would really scare me. Unfortunately, we are in that situation. And what I want to do today is to quickly go over some of the biology of the disease, and then go into our preparedness. And then the most imminent thing that we're looking at is what we're talking about is our disease process, as well as preparation through the surge. Let me see if I can go. Okay, hang on, I apologize. Okay. So we'll talk about preparing for the surge. What is the surge? Why a surge occurs, our capacity, modeling, how to prevent it, and how to prepare. So first, I want to go over the importance of why this disease, COVID-19, has created such a havoc. And here's the reason. Number one, if you look at the infectivity of the disease, usually what we see diseases such as the flu, it has one person infects another person. So infectivity in terms of is about 1. Measles, as we know, is quite infectious. Almost 16, one person infects 16 people. What we are finding with COVID-19 is one person is infecting 2.4 people. And that is what's creating such a large pool of infected people. So compared to the flu, it is more infectious. Now, the other problem with COVID-19 is that it has a higher mortality. So with the flu, we see a mortality rate of 0.1%. So 1 in 1,000. However, with COVID-19, we're seeing deaths maybe 10 in 1,000 or 1 in 100 or even more. Now, all of this is further complicated by the fact that this disease, COVID-19, the virus, is quite infectious on surfaces as well. So studies from a New England Journal article found that you could find it on plastic for nearly 3 days, on stainless steel for 2 days, on cardboard, where there was a huge concern whether the boxes coming from China, if they could be infected, and we know that it can be there for a day. But even in aerosolized environment, it can be there for about 3 hours. Copper is about 4 hours. So again, you mix all of these things together, and then you get a situation where there is a virus which can cause tremendous havoc. Let's put that into context of other illnesses which cause death and disease. Seasonal flu may kill up to 61,000 people. Usually in the season, it's more 40,000. This is in all of the United States. What would an opiate epidemic is at about 70,000. The estimates for COVID-19, very unclear, as you can see in the news. The models change every day. Something between 30 to 300,000. We don't know, but the number would probably be somewhere in between. Still, compared with the influenza pandemic of 1918, significantly lower number of deaths, but again, significantly more than the flu. So that's why we worry about COVID-19. I want to take a minute and talk about it as a clinician, where and how patients present for COVID-19. So we, as ID doctors, we're seeing a lot of patients. And just to walk a timeline for this, I think it's important. Suppose you or I were exposed to a patient today. About 5 days down the line, the incubation period is anywhere 2 to 14 days, but around 5 days, we may develop a sore throat, fever, and the symptoms are completely varied. There is folks who are very asymptomatic, but then those who are quite symptomatic and ill. And then a person usually gets tested by day 8, and then the result comes back 2-3 days later, and the health department is notified, and the health department does contact tracing, and generally people will feel better and they're out of isolation within a few days. I walk you through, this is when person does not have complications. However, when someone does have complication, the timeline is somewhat varied. Again, symptoms may begin by day 5, but then there's initial phase, they might get better or it may not be significant. But the second phase, which is more the ARDS type phase, is when people get quite ill. And that's when shortness of breath, cough gets worse, they get admitted. Within a few days, they get into the ICU with the ARDS type picture, and there's a complication. So I share these two scenarios because this is how patients are presenting in the clinical perspective. what's really important also to remember is sort of the broad picture. And I draw this pyramid just to sort of highlight what we are seeing. Suppose we test 1,000 people with a flu-like illness. You've heard about ILIs, influenza-like illness. That's how many patients present to us. If we test those, right now in Tennessee, in Memphis area, what we're seeing is 10% of those, which is about 100, will be positive for COVID-19. So out of those 100, about 15 to 20 will be hospitalized. The other one would be mildly symptomatic, but would not require hospitalizations. Of the 100 that were positive, 7 will end up in the ICU, and 3 to 4 may be vented. So this gives you a sense of sort of the cascade of events that happen in a patient's process in COVID-19 disease. And then there's a mortality rate of 1 to 2% of the 100 who returned positive. I show this for especially those who are planning disease preparedness, because it helps them see how many patients that we will need, how many hospital beds we will need. Now I want to take a minute and talk about the surge. So what is a surge? When we begin to see an excessive number of patients at a particular time, that is what we are calling a surge. And so what we're seeing in New York City, what we're seeing in other places is a large number of people coming in a very short amount of time. And so what we're talking about is this excessive patient coming in, and yet the capacity of our healthcare system is not there to manage these patients. And so we have a scenario where we are incapacitated and we're not able to take care of patients as we would otherwise. Let me talk about what was the model a week ago. So a week ago, when we were looking at the prediction models, this is a University of Washington model, which has been shown quite often. What the thought was that the surge would occur somewhere in the middle of April, and yet it would be in the range this is numbers for Tennessee, that we would have something in the range of 16,000, it'll be require almost 16,000 beds, whereas our capacity was 8,000 beds. So you could see that there will be, that according to the model at that time, 2 weeks ago, that we were going to see an exceeding number of patients. However, what the changed model as of last week is significantly different. And what this is showing is that what we will have a surge, but this may be significantly lower, that only about 1,200 beds will be required. And our availability is 7,800. So we are well within our scope of managing and treating such patients. Now, you may be wondering, why is there such a huge discrepancy? Why is there a change in the modeling? Well, there are multiple factors, but one of which is that the model is taking into account that there is 100% social distancing, and I'll talk more about what that is. 100% social distancing that occurs over the period of time all the way until end of May. And that's why some of these numbers look so good in this model at this time. So what is the true answer? We really don't know, but I believe that in general, what will be our requirements that we will need to do is to prepare for some level of greater number of beds requirement. Here's another model which shows that there will be a need of over 6,000 beds, and this is for Shelby County region as well. And this is from a UPenn model again. So very simply, we need to be prepared that there might be an excessive number of beds that we'll need. How many? Maybe twice as many, if in the worst case scenario. Ventilators, maybe 3 times, and ICU beds, maybe 4 times. And so there are preparedness across the state because we do not want to be in the same situation as we were in New York City. What can we do to mitigate this excessive number of beds? In fact, we're already doing this and we're seeing the impact of this. And it's through social distancing. You see, the virus feeds on our social interactions. We know very well that it's going from person to person through the respiratory route. If we reduce or eliminate those social interactions, we literally starve the virus because within 14 days, it can no longer replicate in another host. And our own immune system destroys that virus right there. And so what we do by doing social distancing is we flatten the curve or we dampen the surge. And that is what we're seeing here happening. Now, mind you, we lengthen or we prolong the epidemic as well. But just imagine how many lives we would have saved and we would not have incapacitated the healthcare system. Now, all that was theoretical, but I want to share with you an actual scenario that happened in 1918. So in 1918, Philadelphia and St. Louis took very different actions. In September 17th was the first case of the flu in the 1918 flu pandemic in Philadelphia. It took them over 2.5 weeks to take interventions for social distancing. And that was quite late because they were already on the surge occurring and they experienced excessive number of deaths. You compare that to what St. Louis did. Just within 2 days of the first case, they implemented social distancing. And what they saw was a reduced numbers of death. And what you saw here was a second wave that can occur. And so that is a potential downside of dampening the curve, but you can certainly see that we have a significant impact on reducing the number of deaths that occur and that the health system not being able to manage. So all of this sort of circles around this fact of social distancing, how much people move, the stay at home and safer at home, home shelters, all of these are ways that the political and the leadership from the state and the county, as well as the city level, can allow us to not spread the virus. So social distancing activity is measured in various ways. This is one website, unicast.com, which grades individual counties on how well they're doing in terms of decreasing the mobility. And this is based on cell phone data and decreasing non-essential visits as well. Here's a website and an app that you can download. It's available for Android and soon will be available as well for iOS users. And it alerts for how crowding is occurring in certain areas and also allows people to see how many encounters that they have had. So what do I mean by social distancing? So in a way, we can look at what we call a proximity encounter, how often, how many times you were within 6 feet of an individual for more than 10 minutes. If you're home alone, you know that the proximity encounters are 0. If you have a family of 4, then you're at about 3 because you have 3 interactions. Between home and work, maybe around 10. But now imagine you're at the church or you're in a setting, you'll be maybe 25, and then a large event, you can imagine having more than 50 encounters. And you know very well that what has happened at Mardi Gras, it was exactly where several individuals or many individuals had COVID-19 virus, and then it spread to a lot more. I'll finish up. So what will be the end game with COVID-19? How will this end? It will require extensive amount of social distancing. We need to do testing, because we need to identify those individuals who have the virus. Then we have to do contact tracing, isolation, continued surveillance, and our hope is that a vaccine will then be able to contain the virus. And so we do not have to have this level of concern every time we're seeing patients with a flu-like illness. We know that this is a strategy which works. There are a number of articles on controlling COVID-19 by isolation and case contact until we have a vaccine. This is our best strategy. And then the question comes in, if we are going on that path, how do we begin to reopen our society? How do we reopen Tennessee? How do we reopen America? In fact, I have a piece in the local papers as well as the national papers about reopening America. And a lot of it material comes from this piece that's by Scott Gottlieb, the former FDA commissioner. And it's about the steps that we will need to take. So with that, I'll finish up. I want to thank you for taking time. The slide sets will be available for you as well. But I just want you to think that right now, the most important strategy for us to dampen what happens 14 days from now is the fact that we can do social distancing and dampen the curve. So Clint, I'll pause with that and see if there are questions.
All right, thank you, Dr. Jain and Dr. Fiscus. Now we're going to begin a question and answer segment. I believe we had some questions asked in advance, and I would ask Mr. Cummings to please open his microphone. And Clint, go ahead with any questions that you have.
Yeah, so we were able to get a few both in advance of the meeting and some on the chat feature. And Dr. Jain and Dr. Fiscus, we may also ask you, some of the general questions that you're getting, and we can add that to the recording. So the first question came in advance. It says, why don't we do the quick antibody test for staff who are involved in the frontline care of patients? Why not get this test covered by insurance so all clinics can offer it? And then the person offers to assist the government for this.
So Dr. Fiscus, you want to address that, and I can add more? I think you're on mute.
Your phone's on mute.
Okay, well, I think she...
Try with just your cell phone, Dr. Fiscus.
Okay, I think she might be coming on.
Like your phone, hold on one second. How about now, Dr. Fiscus?
Ah, now I am. Okay.
Gotcha.
Okay, thank you. Sorry about that. So the rapid antibody test, for starters, we don't have a lot of them available. I think the state lab was given 150 of those tests. They're trying to ramp that up to make those available across the state, but as of today, right now, we don't have wide availability of those tests. All of the insurance companies, including TennCare, are covering testing for COVID-19. I haven't seen anything to suggest that it matters which test is used for that, so it should be covered by insurance. The problem would be for those who are uninsured, and anyone who's uninsured is able to get that testing through the state public health lab.
Right, and I'll just add to that is, I think as the tests get ramped up, the testing for antibody and testing for the PCR, the test that we're doing now, can be used strategically by clinicians. So the antibody test would help us know if someone has had COVID-19, if the IgG is positive, and then they would not be at risk of contracting it again. the PCR test is very helpful to know if there is active disease at present. And so that's, those tests can be used strategically. And the sensitivity generally for the PCR is higher than the antibody test.
Yeah, I'll just add to that, that with the antibody test, it also depends on which antibody test is being used. Some have specificity to COVID-19, but other antibody tests do not. And so you can have a positive IgG or IgM because you have had a previous infection with one of the commonly circulating coronaviruses as well. So it's important to understand the specifics of the test that's being offered.
The one question that came through on our chat was a pretty good one. This physician is looking for recommendations for patients with COVID-19 who are now eligible to return to work. This particular physician is telling them 72 hours fever-free and 7 days since the onset of symptoms. She's giving them a note without repeat testing. She wants to know if that's okay. She did read this on cdc.gov, she says.
Yeah, so there's two different ways to clear someone out of isolation. One is what the original CDC guidance was, which was to have 2 negative PCR tests after that 7-day isolation period. The second is to go through 7 days of isolation plus 72 hours of being without symptoms. So if you're without symptoms on day 4, your isolation can end after day 7. But if you're still symptomatic at day 7, you would need to wait until you had been asymptomatic for 72 hours before you would be considered cleared to go back to work.
I'm actually looking through some questions from some previous calls. Do either one of you want to address, some of the common questions that you're getting?
Sure. Dr. Jain, you want to go first?
Sure. I think one of the questions is about masks and when and who should be wearing masks. So let me first begin with this masks for healthcare workers. We in Memphis have had a guidance document that we encouraged all the healthcare workers and institutions such as hospitals to have the employees and frontline health workers wear a mask. Now, there was obviously a concern because there were not sufficient masks. And so the conversation over the past 2 weeks that we believe that they're important tools to help prevent because there is so much asymptomatic. And the mask can be helpful for several reasons, right? One, stopping the infection from the patient to come to the healthcare provider, but also the healthcare provider may have an underlying infection and they might be asymptomatic and they can still be transmitting the virus and they could get the patient infected, but they could also get their co-workers infected. So the question as to masks and healthcare workers, my opinion is, in general, our consensus in Memphis has been that we are recommending that all frontline healthcare workers wear a mask, that the hospitals provide a mask for the entire day. And so many of the healthcare workers are using that. Just to give you an idea, what I've been doing is using an N95, and then when I'm going into a COVID positive room, I'll put a surgical mask on top with the shield and then go and see the patient at that time. So the question about masks has been there, but I'll ask Dr. Fiscus to maybe comment on her thoughts as well, and then we can talk about masks in the general public.
So we absolutely agree that healthcare workers should be masked while they're in that setting. And some of the early healthcare associated cases that we had were because of physicians or nurses who may have had very mild symptoms, maybe just a runny nose, or they felt a little off, who continued to work in their clinic setting, and then found out later on that they were COVID-19 positive, and we had to do substantial testing and contact tracing as a result of those exposures. So I think we've seen that healthcare workers often have milder disease, and can be people who are spreading that to folks within their clinics. And so I'm quite relieved that we now have pretty much a universal recommendation for healthcare workers to be wearing masks in that setting. Here at Tennessee Department of Health, we have ours on too while we're in the building, even though we're spread apart from each other. And I think the public health message around masking is that that doesn't take the place of good hand washing and social distancing just because people are wearing masks. It's just an additional way to help to protect each other.
So, and then we can now talk about masks in the general public. So maybe Dr. Fiscus, your thoughts on masks in the general public, and what should we be doing for that?
Sure. So the CDC suggestion now is that anyone who's out in public be masked. There is not enough in the way of supply for everyone who's in the public to be wearing an N95 or a surgical mask. And so the recommendation is to use homemade masks, whether they're fabric or made out of some other kind of barrier. CDC's suggested that bandanas can be used. And really the masking there does a couple of different things. It helps to catch anything coming from you as far as respiratory droplets. It helps to provide some kind of barrier to reduce that spread, but then also may reduce the chance that you end up becoming infected by someone else. Certainly if you and the person that you're with are both masked, even if they are not surgical or N95 masks, it's going to be better than having nothing at all. I think the public has taken that up on a variable but increasing level over the course of the last week, and just seeing people in the grocery stores who a week ago were not masking, who now, maybe 50% of them you'll see walking around with masks. I think there's little downside to doing that to help to protect each other, as long as that really conscious hand washing, hand hygiene, wiping down of surfaces and doorknobs and high touch areas is continued too.
So I'll add to that, and I think this is really important. A study done during the SARS epidemic in 2003 talked about and looked at the benefits of masking and hand washing. And what they found was if individuals wash their hands 10 times a day, and that's what I've been telling my patients as well as telling other colleagues. If they washed their hands 10 times a day for, as we know, 20 seconds or more, there was a 55% effectiveness in stopping the virus transmission. And if they wore a mask, there was a 68% more effectiveness, reaching up to 68%. So what I'm saying is now this has to become our norm in thinking about how during a high transmission, during a community transmission of a virus, such as a COVID-19 virus, how should we be behaving? And our behavior needs to be modified. That masking should become commonplace, washing hands frequently, up to 10 times, because it can reduce the chance of the virus transmission over 55% of the time, is really important. So I want us as healthcare providers to sort of have that level of thinking.
So a couple of clinical-based questions that we've gotten in the past, and some we actually didn't answer on previous calls out of Memphis. Somebody wanted some thoughts on the intubation through the plastic bag like they did in Italy. Dr. Jain, can you talk any about that?
So I don't know much details on that, and I would have to get some of the pulmonologists to see if those are some techniques. But I will say that what is really important is individuals when they are being intubated, or if there's a high aerosolized risk, that maximum PPE is worn. So that means an N95 mask. If they're PAPRs, then to be using those, obviously glove, gown, and all of that. I don't know if Dr. Fiscus, if you know about some of the details about using the bags.
Not specifically about that. I know there have been a couple of different strategies. Some folks, I think even at Vanderbilt, have looked into using plexiglass boxes to intubate through. I haven't seen any data or studies on any of that, but completely agree that that full protection with any kind of aerosolized procedure like that is definitely what's needed.
There were some questions coming in throughout about the nasal swabbing technique. I know you all may want to answer that, but I do know that the UT Medical School did put out a video with some further instructions. There may be other videos out there, but UT put out about a 2-minute video to really show that technique, and looks like some folks are, having maybe some challenges with doing it properly. Any additional guidance y'all want to give there?
So I'll add just a few comments on that. One of the concerns we have is if you look at some of the data, and this was in the letter in JAMA several weeks ago, which showed that the sensitivity for even nasopharyngeal swab was in the 60–70% range, meaning that we would have expected much greater for a PCR test. And the reason that could be lower than what we expect is that the technique may not be the best. And so we're really emphasizing, and I'm really hearing this from a lot of clinicians as well, saying that we really need to train individuals on frontline individuals who are doing the swab testing to make sure it's done properly. And that video is fabulous. I would highly recommend that everyone take 2 minutes and look at that video prepared by UT, and it'll help make sure that we're all practicing the best techniques for taking samples. Dr. Fiscus.
Yes, that video is fantastic, and we're circulating it widely here out to our public health nurses. The video actually shows from an endoscopic point of view where that swab needs to go. It's impressive how far back that needs to be, and there is some guidance from CDC about the use of mid-turbinate swabs instead of nasopharyngeal swabs, but we know from the data that we're getting out of the state public health lab PCR testing that we have people who are close contacts of COVID positive patients who are symptomatic and having negative test results, and that has got to be in large part related to the technique that's being used in getting those samples. It also likely has something to do with where those people are in their infectious period, and whether or not they're actually having enough of a viral load to be able to be picked up on the sample. But we know that there's a good number of false negatives that are coming out, and without really good sampling technique, I don't think we're going to be able to be completely comfortable that a negative is a negative in someone who's having symptoms or has had a close exposure to someone who's been diagnosed with COVID-19, just because we can't detect the virus on their PCR test.
And so what we as clinicians are very clear. If we clinically suspect that someone has COVID-19 or it's still uncertain, we still keep them in precautions and we retest. And I'll tell you this, of the many cases that we are retesting, it's coming back positive. It may be they may not have had a viral load at that early time. However, it could be the sampling technique as well. But please, just because a test comes back negative, don't assume that they do not have COVID-19. Maintain as at least droplet precautions. and then retest them again, maybe in a few days or a week.